Hello, this lecture is attention deficit hyperactivity disorder. Two things to talk about quick. I think the terms ADD or ADHD kind of get thrown around. The technical definition, I feel like I like the DSM-5 as ADHD or attention deficit hyperactivity disorder. It was originally thought to be a pediatric disease, and that's primarily who we still treat these days, but about 1 to 7% of adults are actually affected by it. 30 to 70% of children will carry ADHD symptoms from childhood to adulthood. So while children who are affected by it do sometimes outgrow it, if you want to use that terminology, some do not. It is generally more common in males than females. All right. Physiology has to do with catecholamine imbalances. So there's some sort of a miscommunication between dopamine and norepinephrine. And changes in transporter density, probably some serotonin effects too. Clinical manifestations are poor concentration, distractibility. Features disrupt at least 2 domains of daily life, and those are listed there. Self-regulation, hyperactivity, disorganization, and learning disabilities can all be associated with the disease as well. Pharmacotherapy is usually first line. Psychotherapy can be helpful in adjunct, but often isn't useful by itself to reducing symptoms. Usually we do have to manage hyperactivity disorder with medications. Norepinephrine-related pharmacology seems to be the most effective, which means that's probably one of the pathways that's most significant in the brain. And stimulants are still, and have been for years, the mainstay of therapy. So your Adderalls and Ritalins and things like that are and probably will continue to be the major way we treat attention disorders. All right, so what do stimulants do? Stimulants release catecholamines from central nervous system storage sites. So they actually physically kind of force the release of the brain stores of things like norepinephrine and dopamine, increase synapse concentration, which increases it throughout the brainstem. At normal doses, stimulants are quite safe. They don't tend to have a profound effect other than just the desired therapeutic one. There is a fairly high potential for abuse for stimulants, and you could make arguments as to why or how people abuse stimulants, but I think their classification, I'll talk about this briefly at the end, but like study drugs or things like that, a lot of times they get used by people who don't necessarily have an indication or have a prescription, which is abuse, not necessarily like people who are taking them purely to get a stimulant effect. However, that's certainly possible as well, or people who might crush it up and snort it, or take a larger dose than what they'd be prescribed. So yeah, certainly those are an issue too, but there's a wide variety of potential abuse when it comes to stimulants. They are controlled to drugs, which makes them the highest level of legally controlled substances. Legally available controlled substances, I should say. If you look at the clinical evidence, they do tend to be more effective in adults than children. They're shown to improve daily living skills. There's not really a difference in efficacy between the agents. There's a whole bunch of them out there and tons of different formulations as well. So it's a little confusing, but I'll kind of tell you the major things. Basically, I want you to look at stimulants as one whole group of drugs because, again, they aren't different from an efficacy point of view. And then you would have to understand that there's different release mechanisms and things like that, which we'll talk about here. Most studies really only looked at short-term benefits, and there's still question marks on long-term data, and especially with children, like how do kids react long-term, and we'll talk about that in a little bit. Methylphenidate was one of the original widely used stimulants. It's got a lot of different formulations. Short-acting Ritalin is the brand name of this, but it's been generic for quite a few years, and a lot of these formulations are actually generic. There's some intermediate formulations and then long-acting formulations. Again, I don't really care too much that you know all these different ones other than just that long-acting stimulants exist. So let's say you start somebody on a stimulant that's short-acting and they want something that can bridge them throughout the day. Well, there are plenty of extended release options out there. Short-acting stimulants probably only act like a couple of hours, and I'll show you a chart here in a second that illustrates that better. Long-acting, just want to point out a couple things. Concerta is a brand name of methylphenidate that's a long-acting multiphasic release. So here's a diagram of Concerta. It's got different concentrations of drugs in different compartments within the capsule, and there's a little hole in the end. So what happens is it's an osmotic shell. Water goes in and pushes out the drug, and you get kind of an immediate release effect and then a delayed release later throughout the day. So Concerta is a really popular drug choice because it's kind of got a unique delivery mechanism that really works well for people. So the hard part is that you don't want the stimulant to continue too far into the evening because people can have difficulty sleeping. So you don't want it to be too long acting, but you don't want to have somebody have to take multiple doses throughout the day. So that's why these drugs have been really kind of finely tuned and developed to specifically meet the needs of the patients in interesting ways that we don't really see in other types of medicine. Daytrana is a patch, so you can get this as a transdermal patch for people who have maybe difficulty with compliance or something like that. There's a 2-hour delay between putting the patch on. Just like any transdermal product, they don't work quickly. And then, I don't know if that's I think the last one I want to say. This is a broken up Concerta capsule. People, you actually, the shell itself is not fully soluble, so people will maybe see the shells in their stool. So that's maybe something to just consider in case you've ever heard of that or that comes up. This is the duration of action. So you have Ritalin, long-acting, CD, Concerta, and Ritalin SR. So I guess the regular release isn't actually on here. But where you could get closest to the regular release is if you look at Concerta, or actually, wait, no, I want to say Ritalin long-acting. That's a good one. That's a biphasic release. So here you've got the immediate kind of peak, and then it starts to trim down, and then you get another phase of peak. So really, what you're looking at for immediate release product is probably like a 4-hour window of time when you get effectiveness from the drug, and that could be helpful for some people. I've known people who've been prescribed stimulants for short-term use for different parts of the day. Some people might take them throughout the day. Like I've seen patients who take them. Like they'll take a long-acting product in the morning, and they might take another short-acting product in the evening, kind of bridge it over that way. But you can see the different releases. Ritalin, or sorry, not Ritalin. Concerta again has this kind of interesting like immediate release, and then it sort of delays out. Then you get this second peak too, which sort of lasts throughout the day and into the early evening hours. And then by the time it wears off, it should be close to being non-therapeutic, subtherapeutic at that point. Other stimulants, you have dexmethylphenidate, which is brand name Focalin or Focalin XR. So again, comes as a regular and a long-acting. Dextroamphetamine, which is Dexostrat or Dexedrine. Dexedrine Spancels, which is a longer-acting form. Amphetamine mixed salts, probably the other brand name people are pretty well aware of is Adderall or Adderall XR. And this is a combination of amphetamines. So if you look at what it says, it'll say like mixed amphetamine salts or something like that, and it's basically dextroamphetamine and amphetamine combined together in a some sort of a formulation that way. It's kind of unusual. And then there's lisdexamphetamine, which is Vyvanse. Vyvanse is one of the newer drugs, and it only comes as a long-acting, not as an immediate release. Vyvanse is really popular. I'm not entirely sure why, if people tolerate it better or what, but it seems to be a popular choice. Side effects, really, really minimal. Again, at normal doses, probably not going to see it. Cardiovascular concerns, certainly, because these are stimulants after all. In kids, we really don't care too much about this. You aren't going to see a profound increase in any hemodynamic parameter. You might see this in your adult patients, especially if you have an adult who also has high blood pressure or tachycardia or something like that. You might want to be careful and in fact probably avoid a stimulant in those patients. But other than that, the transient increases in hemodynamics probably not enough to matter. Certainly you could have patients who feel like when they're very tachycardic when they take their stimulants, and that might be a problem, and maybe we might want to look at trying a different medication if that's going to make them feel anxiety because of that. But overall, again, the clinical impact is minimal. In fact, there was an interesting study that showed that stimulants might actually protect people from sudden cardiac death, people who have had a family history of like some sort of myopathy that causes cardiovascular injury suddenly. And so again, not necessarily a reason to prescribe them, but it's sort of an interesting clinical side note. Neurologic and psychiatric, so sleep disturbances, certainly we talked about that. Stimulants do suppress the appetite, so especially with growing kids, making sure that parents are on top of making having them eat the appropriate amounts of food. Tic development is potentially something that can occur, but it's not necessarily going to happen. It's a more rare side effect. And then there's, of course, the abuse potential, whether the child decides to take more than they are prescribed, decides to sell it to their friends. All those things are potential possibilities and things to be potentially concerned about with Concerta or with stimulants in general. Priapism is rare, but it can happen to male patients with stimulant use. Other stimulant pearls you may take as needed or scheduled. There's not really a guideline as to how you should prescribe stimulants. It's not a one-size-fits-all type dosing strategy. There are basic guidelines for how to initiate doses and things like that. But overall, you can do whatever works for the patient. So again, I've seen people on fairly regimented multi-drug courses throughout the day, and then I've seen people who just have, take one regular release Ritalin at night if you need it to help you study or focus after work or school or whatever it might be. So there's all types of different strategies when it comes to using these medications. Again, they're relatively safe, especially in small doses. So I think there's a big stigma around them. They're a controlled substance. They're a stimulant. It's like, what about methamphetamine? Is that the same thing? Kind of, but not really. That there's all these maybe things that exist in our minds that prejudices against using a stimulant or having some sort of a hesitancy to use stimulants, and there really shouldn't be. They are, again, quite safe in patients. And our primary population are children that we're using them in, so that should maybe say something, right? Okay, growth retardation in kids, sometimes you do see this. Whether this is related to appetite suppression or the drug itself, we aren't entirely sure. However, overall, the child's growth will catch up. And some patients will go on drug holidays, which means that they can stop the drug over summer vacation or spring break. There's certainly no reason why you have to keep taking the drug if you don't need it for focused activities. So, some children might do very poorly in any environment if they you remove that particular medication. Other children may just really only need it to keep focused on their schoolwork or something like that. So then again, if they're on summer vacation or they don't particularly need it for multitasking or whatever it may be, it's not a bad idea to try a drug holiday here and there. Adults can do that as well. Withdrawal, it's usually quite mild. It depends on your formulation, how long you've been taking it, and how big the dose is. But generally speaking, you might just see kind of an exacerbation of ADHD symptoms. Atomoxetine, or Strattera, is a norepinephrine reuptake inhibitor. It's a non-addictive, non-controlled, non-stimulant alternative for ADHD. It's effective, but clinically speaking and evidence-based speaking, it's not as good or proven to be as good as stimulants. However, a lot of people do respond quite well to it. It is a brand-only medication. Actually, I should change this because it is generic now. Recently generic, so it's not quite as expensive as it used to be. The adverse effects are listed there, very similar to stimulant medications, but again, it doesn't quite have that abuse potential associated with it like a stimulant. I think if you take a bunch of Strattera, you aren't really going to get those added stimulant type effects you might think about when you think about like a drug of abuse stimulant like cocaine or methamphetamine. Antidepressants have been used too, tricyclic, bupropion, MAOIs, which would be your absolute last line of therapy. SSRIs, SNRIs. Usually antidepressants are useful in adjunct, and they're rarely used by themselves. I don't think a tricyclic antidepressant is going to be anyone's first choice. They're going to try some of these other medications first. But a lot of adults who have ADHD also have depression. It's actually a pretty common comorbid occurrence. So having an SSRI or SNRI on board might not be a bad idea. And certainly there can be some synergistic effects there. Alpha-2 agonist, guanfacine, is brand name Tenev or Intuniv. Tenex, or Intuniv. Intuniv is the XR for the long-acting formulation. It's useful mostly in children. It doesn't really have any evidence or much common use in adult patients. But for children who have aggressive behavior or have significant hyperactivity or maybe are responding adversely to stimulants, this is a choice that would work well for them. You can use this in conjunction potentially too with other medications. So you could use it in addition to a stimulant. You could use it in addition to atomoxetine as well. Guanfacine is a clonidine-like drug. It's an analog of it. So if you have an adult with hypertension, we talked about like what if you have hypertension, you can't really take a stimulant. Clonidine is actually a good drug that would help with the hypertension, also would help with some of the ADHD symptoms. those patients. Abuse. All right, we talked about Schedule 2 with prescription limitations. There's tons of studies out there that show that abuse is rampant, drug-seeking behavior. Again, these drugs are relatively safe. There's a lot of people that qualify to take them. A lot of people can present with these types of symptoms. And so there is drug-seeking behavior out there and sales illicitly as well. In addition to that, things like performing arts and athletics, stimulant use can be sometimes perceived as a beneficial, so it might be banned by certain regulatory organizations. Slow release oral stimulants really doesn't produce any type of high, or shouldn't. Again, if you inject it or if you snorted it or did something like that, certainly you're going to get a different effect. But if you just consume them regularly, you probably aren't really going to experience a high, again, unless you take multitude of a dose higher than what should be recommended. If you have a patient who you're concerned about is at risk for abuse or have a history of substance abuse, try a tricyclic antidepressant, or atomoxetine would be the choices to go to. What about patients without ADHD? I heard a good analogy by a professor of mine once that talked about how these drugs kind of work in the patient's brain who has ADHD versus somebody who doesn't. Kind of described it like, think about it like a slow release of norepinephrine I should rephrase it, like a regulation of the release of norepinephrine. So somebody who has ADHD has some sort of area in their brain where the balance is off on how much catecholamine it's producing or the neurotransmitter it's producing and releasing. And what these drugs can do is kind of regulate the amount that comes out and goes through. They kind of likened it to a pop can. So like if you open a pop can, it pops and the fizz comes out right away, versus like if you slowly opened it, if you could do that without like maybe putting a piece of tape over and then taking the tape slowly off the top so the fizz kind of gently comes out. That's sort of what these drugs are trying to do, to regulate that process to mimic more of somebody without the disease's effects that they would have in their brain versus somebody with. So I kind of like that analogy personally, or that discussion personally. It makes sense to me, and I think it makes sense to patients as well. Anyway, so do you have some kind of imbalance to get positive effects? No, you could get some effect. Like if any of us who don't have ADHD take a stimulant, we can get some focused effects from that. But we also might get more adverse effects from it, and than somebody who doesn't have somebody who does have the disease. So yes and no. Some people may not be as effective. Some people might just get adverse effects. Maybe they feel jittery or tachycardic or something like that. Anyway, the jury's really out on this. So that's the question that comes by. Like, why are all these people undiagnosed ADHD who are taking these drugs illegally or trying to get them from their friends or borrowing them or buying them? It's probably just because they're trying maybe to get an edge, or maybe they feel like if they need to pull an all-nighter, this is the way to help them. I mean, it is a stimulant like other stimulants, like caffeine or anything like that. It will promote wakefulness and some heightened sense of concentration, but it will affect people with ADHD and people without slightly differently. And again, how that does is difficult to say. But again, the jury's kind of out on exactly what happens with that. So if you have a patient you're trying to treat initially and they don't have any history of drug abuse, you're probably going to go directly to a stimulant. Pick a formulation. Think about when the person needs the concentration. Is it work related? Is it after getting tasks done after work? People will respond in lots of different ways and develop kind of internal coping mechanisms with these. So figuring out what's best for the patient, again, isn't going to be a one size fits all, but certainly look at your formulations and figure out if there's one that makes sense for a patient. If they have a history of abuse, or if stimulants are either non-desirable for the patient or not tolerated by the patient, atomoxetine or tricyclic antidepressants are kind of your third line for adults. For children, you would go to guanfacine, or you maybe consider clonidine if you had an adult with hypertension. Not responding, maybe try a different stimulant, combine classes, or considering adding an antidepressant to an adult patient for that synergistic serotonin effect. Okay, that's all I've got for ADHD.